Welcome to the CME. Today we have chosen two interesting topics, and I'm very glad to introduce the speaker, Dr. Chandana. I always say that he's a brilliant character, and he is the consultant anaesthetist at Balapitiya Hospital, and he has updated, I think, 3-4 ICUs, including our ICUs, and as you know that he's a person who is studying most of the articles, and he's more than anything else, he's studying his own patients and coming out with new ideas. So that I appreciate. I mean that we need that sort of people to this country. So he's applying whatever his theories into the patients and coming out with new ideas. And of course, at this point I must thank Dr. Karunaratna for helping all of us. I mean, some consultants and postgraduates. Whenever there is a difficulty in ventilation, we always send my message or whatever to Chandana, and he has saved many patients, and so I appreciate. So he is going to talk about avoiding rescue therapy in ARDS. So I think ARDS is one of his pet topics, and I know that. The second speaker also I will introduce at the same time, Dr. Nuwan Ranawaka. Is another very energetic character, and I think he is the third intensivist in this country, third intensivist who got board certified. And again, very thankful to Nuwan Ranawaka. All of you know him because he is very helpful to not only to critical care fraternity, to even the anesthetic team. Whenever we are having difficulties, he is always obliged to come and help whenever we are finding difficulties. And he's at the moment he's working at cardiology unit, and I'm sure he must have saved many patients with his current knowledge. And he's another person who is very updated with this whatever is happening with critical care. I like that sort of people rather than just working and applying whatever you have learned in the past. So, and applying his knowledge. He's going to talk about the paradigm shift of extracorporeal life support. I think he has got experience certain patients. So we'll start. Sorry we got late today, so we were waiting for the crowd. So I invite Dr. Karunaratna to have an interactive session. Thank you.
Thank you, madam. It's difficult to have interactive sessions sitting over here, but I'll try my best to be interactive. Now, so the topic today is avoiding rescue therapy in ARDS. Now, we all have been managing patients with ARDS with varying degrees of success. And we know that it's actually a nightmare to manage a rapidly worsening lung condition in spite of all the theories we know, all the latest and greatest, most updated lung protective strategies. You try all your clinical pearls, you have gathered during your entire medical career, but the patient gradually worsens and dies in front of your eyes. It's not that there is something wrong with your clinical pearls. Probably we did not use those pearls in a useful or systematic way. Now, I assume that you have managed patients with ARDS. You know about the basics, at least about the basics of ventilator modes and settings. So this lecture is actually not focused on giving you the latest academic updates, What I'm going to show you is how important the practical application of theories you already know to look after a patient with ARDS, to prevent a patient going into a severe ARDS with, say 100% oxygen, with very high pressures, where you can't do much other than going into rescue therapy. So my idea, so this is not from a particular textbook or an article. So these are all from what I learned in the past, my previous teachings, my experience over the time, managing patients with severe ARDS, because I've been managing patients not only in my ICU, memorize. So I'm not trying to teach you manage or how to manage very severe ARDS patient who is on 100% oxygen and very high pressures, having only few hours to live. I assume that you know the basics of ARDS management, at least to a very basic level. I'm trying to teach you how to prevent an ARDS patient going into severe form where you need ECMO therapy. So, and the other thing is I'm trying to convey a few simple but very important, very practical messages. So just focus your attention to the lecture from the beginning to the end. Otherwise, you will find it difficult to get the entire message. Now, so I'll start with the typical scenario. So this is a 45-year-old patient with ARDS following a viral infection, getting tachypneic, hypoxic in the ward. So we have tried this, CPAP, BiPAP in the ward, and for a couple of days, but saturation is not picking up. Initially, it improved to say 100% with 50% oxygen, but later on, patient needed more and more oxygen, and now saturating about 90% with 0.8 FiO2. Now, this sounds very familiar. And then patient struggles and he doesn't want to keep the NIV mask on. So that's what, so then because the patient is getting worse, now we thought of sending the patient to ICU. So patient was admitted to the ICU, intubated, sedated, and as usually you put them patient on SIME pressure control. Now when you look at this patient, he is acidotic, he is breathing with large tidal volumes, he has a pH of about 7.28, he is breathing spontaneously, taking large tidal volumes, around 700, 900 tidal volume, with a pressure control of 20 and a PEEP of 5, FiO2 of 0.7. Now because he is taking large tidal volumes, the pressure control level was reduced gradually with an intention to reduce tidal volume. Now he takes about 600, 700 ml tidal volume in spite of reducing pressure control even down to 10. Now he is taking large tidal volumes. He's struggling a little bit. So someone suggested to paralyze the patient as the patient struggles and fights with the ventilator. So one bolus of atracurium was given. The moment you give atracurium, the delivered tidal volume dropped drastically to 170. So if you have been managing ARDS patient, you must know what happens when you paralyze certain patients. This is what happened to the patient, and blood pressure started dropping. So the paralysis was omitted. Now patient continued to breathe with a lot of effort, but blood gas was normal, pH of 7.45, saturation was 98%, but you needed gradually increasing FiO2. So this is what generally happens in ARDS patient. Then the PEEP increased to 10 as the patient was needing more FiO2, and we keep on increasing the PEEP up to 18, and each time you have some degree of improvement in oxygen, saturation improves transiently, but gradually over a few days, saturation dropped, and patient started deteriorating, and carbon dioxide level was rising, but pH was maintained around 7.3. But later on, patient needed 100% oxygen with a PEEP of 20. So this sounds very, very familiar. Now they started paralyzing the patient. So when you paralyze, patient needed very high pressures. Pressure control level of 39, PEEP of 20, rate of 28, and we tried even the inverse ratio. Blood pressure started dropping and a fluid bolus was given. but still did not have enough blood pressure, and you start noradrenaline, and next day patient is on 3 inotropes, chest X-ray is worse, so you thought of putting the patient on prone position, you attempt prone positioning, and then you suddenly get a drop of blood pressure with bradycardia, almost had a cardiac arrest, but did not have cardiac arrest because of CVP was disconnected. Prone positioning at that time, although we tried for a day, but did not help the patient and he died. Now, so this is a kind of common thing with severe ARDS. Now, but we have been learning a lot of educational stuff on how to manage ARDS, a lot of clinical pearls. Now, what happened to those pearls? So, like, we have been learning, but I'm suggest by pearls here, like, oxygen dissociation curve, oxygen delivery, all these cellular processes happening inside the cell, oxidative pathways, lactate and global hyperperfusion, low tidal volume, ventilator-induced lung, so many clinical pearls. But if you look at the case we just discussed, now the pearls were dispersed all over the place. Now if you link it orderly, so you get a very nice necklace. So to link all these clinical pearls, what I suggest is there are 2 main threads you have to use to link these pearls into a very beautiful necklace. So those 2 pearls are, first one is adequate oxygen delivery. This is very, very important. So without having the idea of adequate oxygen delivery, all these different measures you try in different articles and guidelines will fail. Because you need oxygen to live. You need only 2 things to live. Basically, the rest of the thing body can look after. If you give them energy, the body can produce energy, so you give them oxygen and the nutrients. So the cells can replicate itself, and nature can look after the body very well. If you provide those 2 things, oxygen is the most important thing. So without adequate oxygen delivery, your pearls will be dispersed all over the place. The other thing is uninterrupted lung protection strategy from the early stages of the ARDS. This is very, very important. So if you don't have those 2 things, then you get more patients dying of ARDS. Those are very simple things, but it's very, very important. Once you start practicing those things, then you will realize. So, okay, what happens in ARDS? So we'll take an example. Say you have a patient with acute lung injury due to a viral pneumonia. So, okay, we'll first forget about the lung and we think of the whole body, the entire body. If you have a viral infection, when the viruses get into our body, you get the virus get into the cells and they use our own system in the cell to produce their own proteins to replicate themselves and then destroy the cell. Then they go to the adjacent cell. So this process happens, over and over again for about few days, maybe a week. So when you get a viral infection, after a week, you are back to normal. So the viral illness lasts for a short period of time. Say you have a viral pneumonia. Now the virus is in one of the most important organs in our body, which is lung. So but the cause of illness will be similar, but the symptomatology will be different. Because it's the lung which is so when you get severe symptoms and you sometimes start ventilating these patients. So when you try to, any patient, when you try to ventilate, even normal person, you cause a lot of lung injury. So you can't prevent lung injury altogether up to 0 level. So, but you can actually avoid additional lung injury. Then you can look after the lung in a way if you want to protect the lung. So in these patients, when you lose the lung, patient dies at the end. So, but the thing is, the idea is to look after the patient once the viral illness will disappear. Now, most of the time, viral illness is not there after about a week or so. So, you are managing ARDS now, which is actually perpetuated because of the ventilator strategies you have been using. Viral illness, so if say you have some kind of virus, you no longer have virus in the body, but you still manage ARDS for months and months, weeks and weeks, because you continue to damage the lung without your knowledge. The lung is a very delicate tissue. All of you know that lung is a very thin membrane. It's only 0.3 micrometer in diameter, allocapillary membrane. So, if you look at in the first day, the lung may appear normal, but after about a week, you get fluid-filled alveoli, which is useless when it comes to gastric state. Okay, now the thing is, the damage is not so obvious. This is the biggest problem. Now, if you give a large tidal volume in early ARDS, you actually get much better blood gases, much better oxygenation. You will have a very nice saturation, but you continue to damage the. How can that happen? The reason is oxygen only diffuses. It's only simple diffusion. There's no carrier molecule. There's no active transport of oxygen. So it just, even if you damage them, even if you crush the alveoli, you still get oxygen going into the blood. If you have that thin membrane, because it only affects the fixed flow of diffusion. You know, the concentration gradient, the those kind of things. So even if you damage the alveoli, you still continue to maintain your saturation. It's very important to understand. Lung damage, you cannot see by looking at the blood gas in the initial part of ARDS. You can see the trend of, PO to FI2 ratios, but still lung damage is not that obvious. And even if you take a chest X-ray, you may not see them. Like, say, for example, you have a patient with ARDS, somebody comes and puts 750 ml tidal volume. And you do a chest X-ray after half an hour, chest X-ray is much clearer than before. Because X-rays will just travel through the body. It does not know whether the lung is having ARDS or not. So when there is more aeration in the lung fields, you will have clear fields. So they are misleading to get the idea about the lung injury. So lung injury, so you have to be very, very careful. If you need more and more oxygen, there is something happening. So you must do something even if your saturation is normal, even if your chest X-ray looks normal. When you need 100% oxygen, when your chest X-ray is normal, it doesn't mean lung is normal. So lung is pretty bad. Right. So damage after about a week, so you will have fluid-filled alveoli, which is useless. The other thing is damage is not readily reversible. Now, for example, you can get this kind of fluid coming into the lung in acute pulmonary edema, which is a transudate. You can apply a PEEP, you can sit the patient up, you can give diuretics, you can give vasodilators, you can do various things to get rid of that fluid. When you apply a PEEP, the fluid you can push that fluid out of the alveoli, and then the lymphatics and all these diuretics, all other measures can get rid of fluid. But in ARDS, what you get is an exudate. So once you get exudate happening in your alveoli, that alveoli is gone. Like gone forever. You can't use that alveoli. Very unlikely. It sometimes can, but most of the time it's useless. So the idea is to prevent further lung injury. So this has to be done from the early part of it, not when you have a patient who's on 100% oxygen, when you need very high PEEP. So you have to look after the lung from early parts. As I said, those are very important. Simple looking sentences, damage is not so obvious. So you must remember that. So in the early part of ARDS, you have to look after the lung. Otherwise, you will end up next week very bad ARDS patient. And it's not reversible. So you try all your measures from the beginning not to have more exudate in the lung. These are simple looking but very important. You can damage the lung with very, you will use, some people actually use large tidal volumes in certain ARDS patients, because the moment you give large tidal volumes, oxygenation is better, pH is, so all of you want to keep the pH to a perfect value, which is wrong. Most of the time, you don't need if you try to get a perfect pH of 7.4, you will have to damage the lung in ARDS. So in other conditions, like in DKA or some other metabolic causes, probably you can try that one, but in lung condition, the primary patient is dying because of lung injury, you must protect the lung. You must protect the lung during this viral illness, some kind of illness, primary insult, which will last only a week or so. But if you look after the lung, having adequate oxygen delivery at the same time, then you can save this patient. Now, when you keep on damaging more and more alveoli, those alveoli become fluid-filled and unusable. So the alveolar volume reduces. So we call it functional lung volume reduces. So when the functional lung volume reduces, we call it a baby lung, because the functional lung volume is very little. So you cannot accommodate the same tidal volume you used to take 500 ml in this small tidal volume. If you try to do that, what happens? So you have actually 3 different areas we talk about in baby lung, not actually discrete areas, it's all over the place. Like in the other side, you have fluid-filled alveoli, so you have 3 different lung. One is normal lung, and you have unusable fluid-filled lung, and you have recruitable lung in between. So the idea is to protect the normal lung, recruit as much as recruitable lung. So recruitable part of the lung, after about a week or so, you don't have, lung is damaged.
So you have to protect the lung. If you protect in the early parts, probably you can recruit. Most of the you don't try recruit maneuver because patient is having good saturation. But of course, recruitable lung has to be recruited using various methods, not necessarily a large recruitment maneuver. But you have to have the idea of recruiting those alveoli. Now what happens? So if you try to give a normal tidal volume to this patient, so you're going to overexpand the normal alveoli and you're going to damage normal alveoli. So you should never do that, like trying a very large recruitment maneuver in the patient where there is no recruitable lung tissue. So you must know how to find out. I'll teach you certain tips of how to find out recruitable lung tissues. So I believe now you understand the most important thing in ARDS management is prevention of further lung injury than management of established acute lung injury. Because once you damage the alveoli and fill it with exudate, it's extremely difficult to get rid of that fluid and make that alveoli usable again. So prevention is the best. So this should start right when you see the patient first, not when the patient is having, on 100% oxygen and very high pressures, having a very low saturation, where that time you will need some kind of rescue therapy. Even the Suddha fellows, they, in all those countries, they find it difficult to manage already established lung injury, like severe ARDS, whatever the technology they have. And it's actually very important to concentrate on these important aspects rather than trying to concentrate on, lower inflection point in low flow pressure volume loop, or so, some kind of advanced ventilator modes, APR. So those are important tools. If you know them, you can actually use them. But it's more important to understand the ARDS lung damage is not so obvious in the initial period. You must protect the lung from the initial period. And so we'll talk about how lung can get injured. So how can one add more lung damage? By putting a patient on a ventilator. What actually damages alveoli, in addition to this primary pathological insult? So you must have heard about barotrauma, volutrauma, atelectrauma, biotrauma, this kind of various kinds of trauma. So those knowledge, you should not confine that knowledge into your theory exams just to pass exams. So they have to be applied on the patient management. Now, ventilator-induced lung injury is not a theoretical case. It's actually happening in each and every patient when you put them on the ventilator. So so in animal studies they have seen, so if you apply high pressure to an animal lung for about even a short period of time, then you get significant amount of lung injury. So this is what happens in human lungs also. So there are so many mechanisms, but I'm going to concentrate on two main mechanisms, which is repetitive opening and closure of alveoli. So especially when you have a lower PEEP. When the alveoli collapses and opens during tidal breathing, you get lung injury. This is one of the most important mechanism of lung injury. The other thing is tidal stretch. How fast and how big the tidal stretch is. So amount of tidal stretch, in other words, tidal volume. So we'll discuss about those things. All of you know about this, pressure volume loop, and we have to keep, so theoretical stuff, we have to keep the lower inflection point, but no one really knows how to find the lower inflection point, and to actually, it is useful to keep the PEEP on that level. It's a different scenario which I'm going to talk about. Now, what actually determines the alveolar volume? A lot of people think it's actually the pressure inside the alveoli. Now, if I say when I'm at rest, say after an exhalation, my alveolar pressure is atmospheric, 0. I take a big breath in. So if I check my alveolar pressure, it's once again 0. It's atmospheric because it's connected to the atmosphere. So it's not actually pressure in the alveolar. So you will say it's actually pressure inside the pleural cavity, because pleural pressure changed when you breathe in. But if you take a paralyzed patient connected to ventilator, their pleural pressure will not change. Then you change the alveolar pressure. So they are pressure. So actually what happens is the pressure difference across the alveoli. Now in a normal, say before the inspiration, you have a -4, 5, something like that pressure inside the pleural space. So your transpulmonary pressure, which is the pressure across the alveoli, It's 0 minus minus 4, which is plus 4. If you have a positive transpulmonary pressure, you have an open alveoli. If you have a negative transpulmonary pressure, you have a collapsed alveoli. So in ARDS, if the outside pressure is, we'll say, plus 10 around the alveoli, and you have a peak of 5, you have 5 minus plus 10, which is minus 5. So you have a collapsed alveoli. So when your pressure goes to 20, it opens up, and it collapses and opens up during tidal breathing. So that causes repetitive opening and closure of alveoli, which is one part of lung injury. So it's important to understand it's actually transpulmonary pressure. So when you take a breath, say you have a transpulmonary pressure of plus 10, and you close your mouth and nose, and you push the lung, you do all sorts of maneuvers, but still the transpulmonary pressure will not change. So in a certain patient at certain point, transpulmonary pressure proportionate to the tidal volume. If you have large tidal volume, you have large transpulmonary pressure. So what is the maximum transpulmonary pressure a lung can hold? So if you take the maximum type of breath, like that, so you generally generate about minus 30 pressure, which is 0 minus minus 30 plus 30 transpulmonary pressure. So you don't measure intrapleural pressure in clinical situation, but you assume you at least try to keep your alveolar pressure less than 30. That is why you try to keep your plateau pressure less than 30. 30 is not a magical number. 30 is the number. So if you have a more than 30 transpulmonary pressure, you get alveolar damage. So it's important to identify this concept. It's actually alveolar volume is determined, or the lung volume is determined by the transpulmonary pressure. So this concept is very important. If a person is taking very large tidal volumes like something like that and taking about 900 ml tidal volume spontaneously when the patient is acidotic, so the nature has failed. Nature is taking very large tidal volume, although the lung is getting damaged, because patient has to survive. Now patients are not, in evolution, patients are not exposed to hyperoxic condition. Like they don't know about, the body doesn't know about the hyperoxic condition. Body generally cope up with, the body has to live, so it will try to take some oxygen and take some more gas irrespective of the lung damage. So if the patient is taking large tidal, that means there is lung damage. So you must control that tidal volume in ARDS, although you need only very low pressure to ventilate these patients. Now, artificial ventilation, I discussed that one. So the plateau, all of you know, plateau pressure is the alveolar pressure, not the peak pressure. So I don't have enough time to go through why it is not the, so plateau pressure is the end inspiratory alveolar pressure. PEEP is your end expiratory alveolar pressure. So I'll give you some example. If you apply same pressure of 34 in a thin individual and a fat person, and the alveolar pressure will be 34, but this one may be having some positive intrapleural pressure. So the same pressure, the tidal volume given to these two patients, the thin patient will have a larger tidal volume. That is probably one of the reasons, I don't know, probably one of the reasons why thin individuals get more pneumothoracic, spontaneous ones, rather than obese ones. Don't try to be obese to get protected, but there are other disadvantages also. So these differences are, all that's so theoretical stuff, though all these changes in transpulmonary pressure, it's actually all over the lung field. It's not in one entire lung. So it's one with several areas. So you can have different areas of transpulmonary pressure throughout the lung, even the normal lung. Pathological lung, it will be exaggerated. So there are regional differences. The other concept I want to talk about is the driving pressure, which is, I told you, the repetitive opening and closure of alveoli can cause the lung damage, and the driving pressure. So this is the person, Marcelo Amato, who actually, it's not a very new concept, but it's getting more attention nowadays, because, so this is actually one of the main reasons you contribute to mortality, and actually showed in the meta-analysis. So if you keep your PEEP constant, I don't have, if you keep your PEEP constant and with an increasing level of plateau pressures, you see the mortality rises with that. So when you have more difference, mortality rises. So if you keep your PEEP and plateau pressure, the difference same, the mortality is kind of static. So there is no increase in mortality. The other thing is, so when the gap reduces, they would reduce the mortality. So it's very important. He has shown the driving pressure is very, very important. Generally, he asked us to keep the driving pressure less than 30. I tried this one when I was in Hambantota. I actually went to one of his lectures. Before he published this article, I went to his lecture. I started practicing that one, and that showed a significant improvement in my ICU practice. So what are the strategies we generally use? We use low tidal ventilation, high PEEP, maintenance of plateau pressure less than 30, permissive high. Those are kind of pearls dispersed all over the place. So unless you have these two threads, uninterrupted lung protective strategies from the beginning and the adequate oxygen delivery, those are the two main important points. If you don't use those two strings to attach these pearls, then you will have a bad outcome most of the time. Well, it's not the guideline. You must understand why the guideline is laid out in such a way. So I'm not going to details about this, different strategies, recruitment maneuvers. I'm going to talk about the aims. We generally, conventionally, when I started my registrar period, so conventionally, we needed to keep the pH 7.4 exactly at that point. So I remember some of our seniors, they actually gave bicarbonate even in the base exercise -3, I remember, in this hospital. We used that one. So that was the practice. And initially it was 10 to 15 ml tidal volume, 10 to 12 ml. I remember some patients were getting ventilated for 700 ml tidal volume, and we add another side with about 1 liter tidal volume on and off to make sure that the alveoli are expanded. Now this saturation. Now that was actually nowadays we don't try to get the best blood gases. If you have the idea of oxygen delivery, you will realize why it is not that important to have the blood gas perfect at 7.4. And most of the time, in our practice, we try to be happy with the saturation we see in the monitor. Saturation, so as I told you, that's very important. We have to have oxygen in the mitochondria to produce energy. Now mitochondria, oxygen, we have to get oxygen from the atmosphere into the mitochondria. Now during this pathway, from the alveoli to the bloodstream, you get oxygen going to the bloodstream. You measure that one using the arterial oxygen saturation, like SpO2 is arterial saturation. It doesn't mean that you are delivering enough oxygen. It only says that you are oxygenating well in the lung. And the PaO to FiO2 ratios will tell you certain ideas. If you aim at those things, you only look at the oxygenation, not oxygen delivery. So when the patient dies, you can get a patient dying with very good saturation. And I saw a couple of weeks ago, there's a patient died in one hospital. That patient had a fairly good saturation, but he had a very low oxygen delivery. So the plateau pressure, these are important aims, but we should, important things to monitor, but this should not be our aim. So our aim should be the oxygen delivery. So I'm not going to discuss about this complex equation, but you all know. So it's not the PaO2 which is important, it's the oxygen flux, hemoglobin, saturation, and cardiac output. So out of these things, body is designed to change the cardiac output to cope up with the lack of oxygen delivery, not hemoglobin, not saturation. Saturation generally is kept above 90%. But the idea of cardiac output is actually lost nowadays because we try to get the best PaO to FiO2 ratios, saturations, and but it's important the oxygen delivery. So compared to best oxygenation versus adequate oxygen delivery, I'll give you one example. Suppose, imagine you have to generally deliver about 1000 ml of oxygen throughout the body. Imagine you need about 500 ml oxygen delivered to a person to survive. Now, there are two examples. The first example, both patients are having hemoglobin of 10. One is having saturation of 87, PaO2 of 55. The other one is having saturation of 100% with a PaO2 of 150. This patient is having cardiac output of 6 liters, the other one is having 3 liters. You can do the calculation using your stuff you have known scientifically. And in a patient 1 survives, the patient 2 dies. Because patient 2 is not delivering enough oxygen to the tissues, but saturation is 100%. So these are known, so these are not new things. What I'm trying to say is, use your knowledge, so you try this one and you will realize how good the outcome becomes. So cardiac output is very important. So don't try to keep a patient at 87 with a cardiac output of 3 liters, then it will be horrible. So you must make sure when you do this permissive hypoxemia, permissive hypercapnia. So you make sure that your cardiac output is good. So when you apply very high PEEP, if your urine output drops, if you have cardiac monitoring, you must check what happens to your intervention to the lung. If you increase PEEP and the cardiac output drops, there's no point. So you're not delivering enough oxygen. So it's very important. So if you look at this one, cardiac output actually has got the first and the most important response to reduction of oxygen delivery. So this is one of the most important things for you to remember. It's the cardiac output, not merely the saturation. Saturation should be the target, but it's not the aim. Aim is oxygen delivery, not the saturation. So I have certain scenarios. I'm going to skip the first one because if I have time, I'll just go through that one. It's important, but because of the time. So we'll see two patients. Patient 1 is on SIMB pressure control. Patient 2 is also on same pressure control level, same 20 of pressure control, PEEP of 8. But the first patient, patient A, takes tidal volumes around 300, 650, sometimes above more than 900. The other patient is having roughly about 360 ml tidal volume. Now first patient is agitated and taking strong respiratory effort. Second patient is unconscious, spontaneous effort was there, but it's not very strong. But you look at the patient with controlled breathing, so they have stopped actually the sides. So this one is patient B, first one. If you look at the transpulmonary pressure, it's about 21. The other one, because it is generating very high negative pressures, is got a 43 of transpulmonary pressure. So if you try to paralyze these patients, if to get the same tidal volume, you must provide the same transpulmonary pressure. So you may need to apply very high pressures if you suddenly try to paralyze, like what happened to our patient in our scenario, which I don't think we have managed well. So paralysis has got different advantages and disadvantages. So we'll discuss how. So that actually, so these patients, the most important thing, the transpulmonary pressure concept. You don't have to check the transpulmonary pressure using esophageal balloon catheter, but the concept is important. But even if you check it practically, the value is not that important, but the concept is important. So this is another scenario. So this patient is on, so this is a common one. I don't know why this happen, keep on happening. So I have had certain instances where patient is on pressure control level of 20 and PEEP of 5 and 100% oxygen. I don't know how it happened. So what do you think we should do in this patient? Saturation is 78, PO2 of 43, but on 100% oxygen, but with a reasonable low pressures. The reason is you have some kind of recruitable lung units which you haven't recruited. If you apply high PEEP, relatively higher PEEP, then you could have reduced this FiO to 100%. So this keeps on happening still. So when you look at this chart, so PEEP, when the PEEP is increased with the same pressure control level, tidal volume initially can come down, but later on, once the PEEP sets in, after about 20 minutes, 30 minutes, you get improvement in tidal volume. Then you can gradually reduce your FiO2. It's a very common thing. I don't have time, but you must know that oxygen should not be, you should not have very high oxygen levels in your blood, which can affect the mortality and morbidity. Especially you should not have anything above 190 of PaO2 is very, very bad. So you must control the oxygen also. This is another scenario, I don't know. Yeah, so I'll just, so recruitment maneuvers, some people don't do this, which is fairly all right. Some people do it just because you know about the recruitment maneuvers, but don't try to apply recruitment maneuvers in a patient in the very late stage of ARDS. Most of the time you don't have recruitable lung units. Patient is surviving with whatever the remaining alveolar units. Don't damage them. So you must, if you can try a rescue therapy if you think that there is no recruitable lung tissue, but if you think there is recruitable lung tissue, then you can apply a recruitment maneuver and learn how to do it. But it's much better if you don't know, just keep on increasing PEEP rather than having a very high pressures damaging the normal alveoli. But I do recruitment maneuvers in certain patients when I think there is recruitable lung tissue, then you can see immediate improvement. But even if you do not get actual benefit. Like you can do a recruit maneuver, you can get an increase in saturation transiently because you stretch the alveoli, damage the alveoli, oxygen just diffuses. As I told you, you don't need any enzyme or intact alveolar membrane, so it just diffuses. So with the concern with the recruit maneuvers is the high pressures. So you want to open up those collapsed alveoli, but this pressure does not know what is your intention. It will be applied to entire lung. So it will actually damage the normal lungs also. So that is why there is conflicting evidence, but if you really know how to apply, then you can get the best out of it. If you know when to apply, how to apply manuals. So what to do when you have a patient with ARDS? So these are my kind of recommendations with the guidelines, and so you may agree or disagree. So everyone will agree they have tried low tidal volume, but you must make sure that you do it with an adequate PEEP. So don't try low tidal volumes in a trauma patient with a PEEP of 0, because you are actually ventilating below your lower inflection point. You are actually damaging the lung if you try very low tidal volume with very low PEEP. So this was applied with an open lung, the low tidal volumes were applied. And you must control the tidal volume in spontaneous breathing patients. If they take very large time, this is very, very, very important, because most of the time, you don't want to paralyze these patients. I'm not asking you to paralyze these patients, but try to control the tidal volume proportionate to the transpulmonary pressure. So if you control your tidal volume, you are controlling your transpulmonary pressure. So what you might sedate the patient, without giving paralysis. Or you can give partial paralysis. Don't be shy to use partial paralysis. Somebody might say you are using some homeopathic dose, but that's okay. We don't want to paralyze the patient completely, but we want to control the tidal volume so that your transpulmonary pressure is maintained in a reasonable level. So if the tidal volume is okay, you can let the patient breathe spontaneously, which is unlikely most of the time. They try to take very large tidal volumes in the early part of ARDS. And so this is once again very, very important. So this is one reason why patients get very bad. Because if you keep on trying non-invasive ventilation on a hypoxemic patient, so if you try NIV, it's okay to try NIV, but if the patient is not improving over a few hours time, you must always think of some other surgery. You can optimize non-invasive if you know a little bit extra, but most of the time, it's better to intubate those patients and control their tidal volume. If you can control tidal volume in NIV, which is difficult, so high flow nasal cannula, NIV, if you try them on hypoxemic patients, they haven't, even in the studies, it's not very useful. It's mainly because it's a diverse group of patients, not because it's not useful. But anyway, if the patient is improving, of course, then you can continue with NIV. If the patient is not improving, don't try NIV for days and days and days. This is very, very common. Even yesterday, I had a patient on NIV for a couple of days, and he got a cardiac arrest. Could have been intubated, young patient. So these are common things happening. So don't try NIV in a hypoxemic patient for days and days. If the patient is deteriorating, if the patient is improving, you can try that. It's okay. And you try to minimize the lung injury by giving a smaller tidal volume, because your lung is damaged. You have a baby lung, you have a reduced functional lung volume. You cannot accommodate more than that. If you accommodate more than that, you damage the normal alveoli. So that is the reason why so when you can't use it, less than 4, it's inefficient, then you'll have to go for rescue therapy. But if you manage the patient from the beginning, and you try to maintain driving pressure, so plateau pressure minus PEEP, that is the driving pressure. So if you have a pressure control level of 35 and a PEEP of 5, you invariably have a very high driving pressure. Although your saturation, everything is good, you are damaging the lung. So saturation is only at this moment, oxygen is diffused to the lung. That is the only meaning. It doesn't mean you are doing good to the patient. Maybe you are damaging the lung. So very high pressures, very low PEEP, you are damaging the lung even though your saturation is very good. And blood gases are good. Blood gases will show in the carbon dioxide, oxygen, doesn't tell you about the actual lung injury. And do not ignore the gradual worsening of the, now you check your PaO2 ratio. If it is above 200 something, if you are happy. So now it was 350, now it's 205. It's okay. It's a slight difference. Still, you are not in severe. So don't ignore that one. It happens for a reason. Maybe patient is in a, like this position, patient, the chest is, shrunken, low FRC, you get atelectasis. So you can improve that position in the patient, doing secretion, sucking out secretion. So you can do something, always try to do something, whether at least increase the PEEP a little bit when you get a reduction in PO to FIO ratio. This can happen because of the illness itself, but you must do something. Don't sit and wait until the patient becomes pretty bad. And don't try to achieve perfect blood gas. I don't have enough time to go through why it's so important, because if you try, in the human body, the acidosis happens to shift the oxygen curve to the right so that you can release more oxygen. So I don't have time to show you how important it is. If you shift the curve, you can extract more oxygen. The tissues can extract more. I don't have time to explain that one. So if you shift the curve to the left, you cannot extract oxygen, even normal amount. So oxygen is delivered to the tissue to be extracted, not to have a very nice PaO2 in the blood. So you must allow the tissues to extract. So when you give a lot of bicarbonate, you shift the curve and you cannot extract oxygen. And don't try to achieve perfect. It's okay to have pH of 7.25 to weight 7.3, and it's actually beneficial in this situation where it will release more oxygen to the tissues. And don't try and never ever keep the pH above 7.4 in this ARDS patient. 7.4 is also bad when severe ARDS. So you have a slight acidosis. I'm not asking you to keep the patient very acidotic, but if you need more tidal volume to have that pH 7.4, don't go for that 7.4 pH. I'm not asking you to keep every patient very acidotic. Always remember, adequate oxygen delivery is the key. It's most important than best oxygenation. Oxygenation is lung, SpO2, that gases. And you can accept permissive hypercapnia when you need to reduce tidal volume, because you hypoventilate and you get carbon dioxide going up, and we console ourselves by giving it a name, permissive hypercapnia. And there is a thing called permissive hypoxemia, not permissive hypoxia. Hypoxemia is in the blood. Hypoxia is in the tissue, so you don't make the patient hypoxic. Permissive hypoxemia, like keeping saturation about 88, 92, but provided your cardiac output is good. If you have saturation of 88, 92 and you have very low cardiac output, like I showed you in the example, patient will die. So you must make sure, so if you want to apply very high PEEP to have saturation of 94, 95, and cardiac output drops, urine output drops, and you need to give some fusimide, that is bad. So when you increase PEEP to some 18, 20, you must make sure that your cardiac output is good. There's no point having good oxygen in the blood if you cannot deliver it to the tissues. If the cardiac output is low, it's going to be useful. So you must make sure that this is very important. These simple things, what I'm going to tell you, I have tried these things, I know the benefits. I haven't done a study, but I know these are very useful. If you really want, if you suspect my thing, you can ask my ICU how. I don't see very many very severe ARDS, because when you follow these things, you can save a lot of patients. So you can, if you have a query, you can ask Tango Hospital or Balapitiya. I actually came to Balapitiya a few months ago. You can still ask, and they know what's the difference in management. And you maintain oxygen delivery. You need oxygen to live. Whatever, it doesn't matter whether you SpO2, whatever it is. So you need oxygen delivery. You can get various parameters. The method you use to measure oxygen delivery will change. It will vary. Maybe it's mixed renal saturation, maybe it's lactate, maybe some clinical parameters, maybe the urine output changes when you apply very high PEEP. So when you observe reduction in these values, when you apply very high PEEP, you don't have to reduce PEEP. You can maintain PEEP, but you correct the problem. Maybe giving some volume, maybe some minor problem. You correct the problem, you make sure that your lung is protected. And you provide adequate. Those are the two main strings to attach these clinical pearls. And the other thing is, do not overload with fluid. In sepsis, you need fluid, that's true. But if you should not keep the patient hypovolemic, but fluid balance is extremely difficult. You can use all your methods, this venous collapsing, all kind of thing, but make sure that you have enough preload, afload, and contractility. So when you give a very large fluid bolus, if you look at the fluid balance in the daily fluid chart and see what the PaO to FiO ratio is. If it is worsening and you have very high positive balance, maybe you have given too much fluid. So it's difficult. There is no one particular way of measuring the optimal fluid balance. Everyone is struggling. No one really knows how to view fluid in this kind of patients. And one of my favorite things, not try this. You may not agree with this one because the guidelines is different. Try not to use volume control ventilation in a spontaneously breathing patient when patient is taking very strong efforts. Because volume control, you use a fixed flow to give the tight volume. So patient cannot take the high flow demand. So patient will be generating negative pressures in your lung, which will contribute to more fluid pouring into the alveoli. And negative pressure pulmonary edema in addition, and they will struggle to breathe. That struggling will cause more alveolar damage, ventilator-patient interactions. So try pressure control. If you really want to use volume control, you sedate them and or the paralyze them. You do something else. I don't use volume control much in the ARDS. So don't try to use recruitment maneuvers just because you want to. In very late ARDS, if you really want to do it, it's like if you get worsening of PO to FI to ratios and otherwise it looks okay, you can try a small version of recruitment maneuver. Don't try 40, 50, you can try even 30. But generally you need high pressure, you can't try 20, something like that. So maybe 40 over, you don't have to apply it like in the textbook like 40 seconds. I have seen if you apply it over 12, 15 seconds, it's more than enough. So don't try to apply, if you apply it over 40 seconds like in the book, maybe you get cardiovascular compromise, blood pressure drop in, so it's very bad. So, you can try recruitment maneuvers if the lung is recruitable. So one reason is if you have very low PEEP, very high FiO2 on a patient, maybe you are doing it wrong, so you have to increase PEEP. You can either do a recruitment maneuver then and there and increase PEEP, or if you know how to check in a low flow pressure volume loop in certain ventilators like, I can't tell you names because it becomes so if you know how to check that one, if you really are interested, I can explain in a different time. Low flow pressure volume loop to find out. So basically you have bigger hysteresis, bigger in that volume loop, then you can see whether the lung is recruitable. And you always remember, you can actually apply increasing level of PEEP. That is also recruitment strategy, although it is not immediately apparent. So you can try that one. So in a nutshell, what I'm going to tell you is, you have to protect the lung from the early stages until the effects of initial insult. For example, viral illness, you protect the lung for about a week or so, then you will recover that patient. But if you keep on giving very large tidal volume just to make sure that saturation is 98% or your blood gas is perfect, then you have a patient whose viral illness has disappeared. You have ARDS ongoing because you have damaged the lung. You haven't given enough oxygen. When you don't deliver enough oxygen, you get cell deaths, you get a lot of mediators happening. And all these mediators will cause further injury to the body, the sepsis, ARDS. So this is a complex thing. No one really knows. That is why our guidelines are updated every single year, because you don't know the perfect management. But if you concentrate on these things will never change. You must provide oxygen. It will never change unless for entire lifetime. You must provide adequate oxygen. And you must do something in a systematic way. Other than doing things haphazardly all over the place. So you must make sure when you protect the lung, you have to deliver adequate amount of oxygen. Not supra-maximal amount, not very high amount. You must make sure. So mixed venous or central saturation is a good guide. Nowadays, some people have been, recently I heard some of the registrars, they don't want to use because now the latest guideline says in sepsis, it's not that useful. Maybe it's true because when you have cytotoxic features in the entire body, maybe oxygen is not utilized properly. But the concept of oxygen delivery is very important. So you keep on checking. Recently, I had a patient pancreatitis. Initially, his mixed venous was 85, something like that. Because he was very bad. But once he gradually improved, then he started utilizing. Then you get reduction in oxygen, SVO2. Then I gave fluid and then improved that condition. So if you check that only, you will realize. Recently, I had a patient who died the same day because I told the person this patient is going to definitely die because his mixed venous was 34. No one checked the mixed venous. When I asked them over the phone, I said, "Can you check the mixed venous and tell me the value?" The saturation was 34. Now, I can't save that patient. It's already dying. Few hours to live. So I hope if you got that message, protect the lung from very early stages until the initial insect. And the other thing is delivering adequate amount of oxygen. Do not target saturation, target oxygen delivery. Thank you.
Good afternoon, and my dear colleague, madam, and my dear colleagues. First of all, I would like to thank for giving me the opportunity to have a discussion about extracorporeal life support. So, I'm sorry about pictures are not clear, but today I'm going to take you from this level to a newer level of this. So, but before that, I should say that I don't have any conflicts of interest regarding the issue or any products shown here. Well, now the concept is changing in ICU practice from multiple organ support to a support with extracorporeal therapies. And you are now familiar with renal replacement therapy, continuous renal replacement therapy, when it comes to renal support. And not only that, the therapies are evolving, like albumin hemodialysis for liver support, and plasma filtration and plasma absorption, hemoperfusion for cytokine removal or cytokine therapies. And not only that, extracorporeal membrane oxygenation ECMOs for cardiac and respiratory support. So today, I'm going to introduce ECMO in ICU patients. First, we'll get a real-life scenario. 35-year-old gentleman comes with a 3-day history of fever and breathlessness. And his X-ray on admission is like this. Obviously, you realize that patient may have got pneumonia, probably viral or bacterial, but it seems significant and severe. And with time, it deteriorates, and patient required ventilation. So the patient was intubated and continued on ventilation. But patient still deteriorates, and we may have done all the therapies as suggested by Dr. Chandana, but still patient deteriorated. And the X-ray is like this. And now you can see the magical therapy has been offered to the patient, and you can see the large ECMO cannula in the chest X-ray. And importantly, with this ECMO therapy, patient survived this stage. And you can see, obviously, there are no lung tissues, no lung markings visible in the X-ray, and patient survived. And later, patient recovered. So you will understand that this patient would never survive without ECMO, without that magical treatment. So, what is ECMO? It is extracorporeal membrane oxygenation. You will take blood out from the patient, from the venous system, and pressurized using a pressure pump, which is controlled with a console, and then oxygenated through this membrane, where the sweep gas or the gas mixture is sent by this gas blender, and then that oxygenated blood will be returned to the patient's either venous system or to the arterial system. So we'll discuss a little bit of technical details. First, the pump. And it is a centrifugal pump, unlike the pump you are familiar with, which is a roller pump. And there, inside there are impeller cones, which are elevated and rotated by magnetic fields. And with the rotation in the middle, the negative pressure created, and therefore blood is drawn in. And with the centrifugal powers, blood will be directed towards the peripheries and will be pumped out with that force. And there are flow sensors to measure the blood flow rates. And it is important to use laminar flow, rather this centrifugal pump, rather than roller pumps, because it will maintain laminar flow even with and you may need high pressures and high flows. Even with those high pressures and flows, you will maintain the laminar flow. So that's why the centrifugal pumps are important. And at the same time, you have to realize that it is preload dependent, and therefore the pump, unlike the roller pump, you will need adequate venous drainage maintained for that pump to work. And it is afterload sensitive, and therefore regularly you have to measure the flows with ultrasonic flow meters. And the console, which controls the pump. You can control the revolutions per minute, and with that you will be able to maintain the flow rate. And in addition, pre-pump pressures, post-pump pressures, and post-membrane pressures are monitored, along with saturations and temperatures. And there's another important gadget there, which is the hand crank. That means whenever there's a pump failure or electrical failure, you will be able to use this hand crank to continue the pumping effect, otherwise patient would die. And the most important part in the ECMO is oxygenator or the membrane lung. It is formed by numerous polypropylene hydrophobic hollow fibers or hollow tubes, through which the gas flows in, and to perpendicularly to that, the water will flow in because you may need to maintain the temperature. And in between these fibers, the blood will flow in. And the diffusion, gaseous exchange happen with the theories of diffusion. And additionally, there's a gas blender or a controller to provide the adequate flow rates of gas, sweep gas, and control the FiO2 or the FDO2, you call it, fraction of delivered oxygen. Even though the current day machines are a little bit bulky, and in time to come, you will use these type of very miniaturized, compact machines with the evolution of the technique. Then, what are the basic modes of ECMO? Commonly, there are mainly three types: VV ECMO, venous ECMO; VA ECMO, arterial ECMO; and AV ECMO, that's arteriovenous ECMO, which is commonly used for this carbon dioxide removal. But what we commonly use is either VV ECMO or VA ECMO. VV ECMO, venous ECMO, you will draw the blood out from the venous system, commonly the femoral vein or from the jugular veins, and oxygenate and return back to the venous system again, and either using two cannulas or single cannula with dual lumen. It is a bicable dual lumen cannula. One lumen is in the, there are two access lumens, one lumen in the SVC, another lumen in the IVC, and there's another separate return lumen which is directed towards the right atrium. So you will be able to use VV ECMO using these cannulas. And if you think of a VA ECMO, veno-arterial ECMO, that is, you will take blood out from the venous system and then return back to the arterial system. And it will support that rather VV ECMO will support the respiratory system, but the hemodynamics will be maintained by the normal native heart. But this VA ECMO, it will bypass the heart, lung, and the heart both. Therefore, you will be able to support heart and lung both when you are using VA ECMO. If you think about the cannulation, you may use larger cannulas, and you can see the femoral cannulas, 2 large cannulas, usually French grade 20 to 25 range, and venous cannula and the arterial cannula. And if you use VA ECMO, there's another important small cannula, that's a backflow cannula, which is connected to the arterial system, which will maintain the distal flow of the leg because of this large nature of the cannula, arterial cannula. Usually the femoral flow is interrupted. Therefore, to maintain the distal flow, you use that backflow cannula. So that's a usual cannulation practice. And then we'll discuss a little bit of physiology. If you use VV ECMO, as I told, hemodynamics will be totally dependent on native heart. And if you get gaseous exchange, there are 2 lungs. One is the normal, native lung, which may be ill and diseased because of ARDS with little contribution. And the second lung is the very, very effective oxygenator. And oxygenation depends on intrinsic properties of the membrane and the partial pressure gradient, that is FDO2, dependent on FDO2, and mainly the blood flow. For a particular patient, these 2 will be relatively constant, and therefore, if you can adjust the blood flow rate, you can see up to a certain point, oxygen delivery will be linearly related for the blood flow. So you will be able to adjust the oxygen delivery by adjusting the blood flow of the VV ECMO. Not only that, and you can see this VV ECMO, even if you return the fully oxygenated blood, and definitely it is mixed in the right side of the heart with the remaining blood flow of the patient. Therefore, the final oxygen content or oxygen saturation or partial pressure of blood will be dependent not only on this oxygenator but also on this mixture. Therefore, again the relative blood flow rate of oxygenator to this remaining venous flow determines the final oxygen content in the blood. But on the other hand, carbon dioxide removal is more easy and simple, and as in the ventilator, it is where carbon dioxide removal is dependent on minute ventilation, and here in ECMO, it is dependent on sweep gas flow rate. And on the other hand, it is relatively independent from the blood flow rate. Therefore, you will be able to use this ECCO2R, that's the extracorporeal carbon dioxide remover. You can use arteriovenous configuration without using pumps, because it is not dependent mainly on the blood flow, but rather just dependent on the sweep gas flow rate. When it comes to VA ECMO, veno-arterial ECMO, It is mainly used for severe cardiogenic shock, where you need to support the heart and the lung, or else if the patient has got a cardiac arrest. You will use now it as ECPR, that is called extracorporeal cardiopulmonary resuscitation, which is another therapy which is evolving. If you get the hemodynamics of VA ECMO, you will realize there are two hearts for the patient. One is the native heart, and the other is the ECMO, which has got a pump. Therefore, the systemic circulation is dependent on the ECMO flow and combined with native heart flow, which goes through the lung. And if you get a total bypass, there won't be a native heart flow, only the ECMO flow, and there will be a non-pulsatile flow in the body, as in cardiopulmonary bypass. But when it comes to ECMO, we would prefer to have a little bit of native heart flow. That's about 20% of native cardiac output and 80% of ECMO flow, because otherwise, if there's no flow in the heart and the lung, the blood will stagnate inside the lung and the heart, and it will get cluttered. To avoid that, you will have about commonly 20% of native heart flow, cardiac output, and 80% of blood flow, ECMO flow, which will generate about with a pulse pressure of 10 millimeters of mercury. So that's the maximum we are going, but otherwise, when you are weaning, we'll gradually reduce the ECMO flow. With oxygenation of blood in the lung, in the systemic circulation, in VA ECMO, you can see the oxygenated blood will be put into the aorta, and from this side, less oxygenated or deoxygenated blood comes because of the cardiac or lung problem to the aorta, and it will be mixed. And this level of mixture is dependent on the ECMO flows and the cardiac flow rates, and where the catheter is there placed, and the remaining lung function. And there's an important, rather interesting phenomena where you can see, if it is not properly managed, the proximal circulation will be deoxygenated with cyanosis, and the distal circulation will be oxygenated. And it can cause interesting phenomena called Harlequin syndrome. With this famous character, you can see the areas of cyanosis, like this, areas of cyanosis and areas of oxygenated flows, which is called Harlequin syndrome. To avoid those problems, there are multiple configurations, as well as to avoid other problems as well. If you think of venous flows, I told that the pump is preload dependent. Therefore, if you need to increase the venous return, venous flow, drainage, you may use 2 venous cannulas to get the blood flow drained. And to avoid Harlequin syndrome, any other problems, you may use 2 arterial cannulas, one main cannula to the arterial system, and remaining a small cannula maybe to the venous side or proximal arteries, and there are multiple configurations. And not only that, if the cardiac function is very, very poor, blood will stagnate inside the heart, and to avoid that, you may fix these left ventricular assist devices to offload the heart as well. And whether it's VA ECMO or VV ECMO, you may combine therapies, and you may combine CRRT with ECMO flows in parallel. Therefore, you will be able to support multiple systems at once. And the other important thing to understand is that ECMO is not the miniaturized cardiopulmonary bypass. You will use ECMO in ICU setup for longer days or weeks, but cardiopulmonary bypass will be used maximally for hours in the operating theatre. And to have a bloodless field, essentially you'll need total bypass for the cardiopulmonary bypass, but ECMO, usually you will avoid that. Since you will get total bypass, there will be blood stagnated in the lung and the heart. To avoid clotting, you will use very high heparin flows to a very high levels of ACTs. Therefore, you will get bleeding to the side. You may auto-transfuse those blood to venous reservoirs. And to avoid the effects, you may use hemodilution and hypothermia. But all those are not practiced and not important or not used when it comes to ECMO. Now, after the theory, we'll get back to the real life. So our patient, 35-year-old patient with pneumonia, we'll start from the beginning. Ventilated for hypoxia on second day with a CME, FiO2 of 100 and PEEP of 20, and partial pressure is 45. Does he need ECMO? Obviously not. You heard the lecture, you listened to the lecture of Dr. Chandana, and obviously you would improve your ventilatory strategies to optimize the oxygenation and the management of ARDS at the beginning. And then you may use prone positioning, paralysis, and again to further optimize and improve the survival. Then, failing which, you have to understand, or you have to ask yourself the question that whether it is worth to apply any rescue method to our patient, because this ECMO is highly invasive and highly complicated therapy. So is it worth to apply that rescue therapy for our patient? And also you will understand ECMO is a bridging therapy. So you have to bridge our patient to some point, either to recovery or to a transplant or to palliation. And you will never ever use it as a bridge to nowhere. And then the next important question is, at which point we should offer ECMO to our patient. There are multitude of data following H1N1 pandemic in 2009, where patients have been put on ECMO. And with registered data, it is shown that the mortality of non-ECMO patients would be more than 50%, so to 60s, and with the usage of ECMO, the mortality would come down to a level of 20s or 30s. Therefore, in the guidelines, it is suggested that you have to consider ECMO if the mortality of our patient is going to be more than 50%, or definitely you have to put on ECMO if it is more than 80%. But the problem is, how do we predict the risk of mortality in our patient? Because We don't have a crystal ball. Therefore, there are a lot of tools developed, and commonest tool which used was an acute lung injury score, which is famously known as a Murray score, where there are 4 criteria: chest X-ray, hypoxemia, PEEP, and compliance, and there are there's a pointing scale or system, and you will add up numbers, and it is shown that it may be related to the severity of the ARDS as well as to some degree to mortality. But the thing is, it has been produced, the Murray score is produced in 1988, and it is not produced to identify the mortality rate. Therefore, its external validity is not very good. Therefore, there are newer complicated tools, ECMONet, Preserve, REST, Preset. There are tools to identify the mortality. And then, if you identify the mortality, and if it is more than 50%, you may have to consider ECMO, and if it is 80%, definitely you should go for ECMO. And in famous CESAR trial, they have included patients if the Murray score is more than 3, more equal or more than 3, or when there's respiratory acidosis with despite optimum ventilatory strategies. But I'm not going to analyze the results here because of the serious methodological flaws in that famous CESAR trial. And the most awaited trial for ECMO, the EOLIA trial, was released about just 4 months ago in NEGM. And in that trial, patients were allocated for ECMO if the patient has got ARDS and ventilated for less than 7 days, because it is thought that if the patient is ventilated for more than 7 days, our treatment would be futile. As you said, as Dr. Chandana said, you have to act early in the disease course of ARDS rather than late. So there are disease injury oxygenation criteria. If the patient PF ratio is less than 50 for more than 3 hours, or PF ratio less than 80 for more than 6 hours, or if there's respiratory acidosis with pH of less than 7.25, despite maximum ventilator strategies, the patients are offered ECMO or to the control therapy. And they have not used ECMO, as I said, if the patients were ventilated more than 7 days, or if the patient is moribund, or having severe chronic diseases, organ failure, limits of care, or if there's any contraindication for anticoagulation. And the other important concept has been practiced by them, that is ECMO retrieval. You will know that all the centers may not be ECMO centers, and you may find very difficult and critical to transfer that type of critical ill patients. Therefore, there should be mobile ECMO retrieval teams where from the ECMO center, the team will go and cannulate the patient in that hospital, and with the ECMO, the patient will be transferred to an ECMO center. There are separate guidelines for that. In that trial, 39% or 40% of the patients have been retrieved, and the retrieval team consists of the perfusionist, ECMO specialist, and a specialist for cannulation as well. And if you go to the methodology of that study, there's an important thing there, concept there, that they have offered rescue or crossover of ECMO to control group patients if the patient is getting deteriorated. It is done due to ethical reasons, and actually in the paper they have said that many investigators felt it would have been unethical to prohibit crossovers to ECMO if the patient deteriorates. That will suggest the current consensus of the ECMO practice in UK and Western countries, where ECMO is now established as a rescue therapy. So, being it unethical to avoid, it seems that ECMO is a must as a rescue. So if the saturation drops for less than 80, they have rescued with ECMO. And if you go to the outcome of outcome of the study, 60-day mortality was non-significantly low in ECMO group. And importantly, if you think of treatment failures of when it comes to ARDS, ECMO failure on ECMO group or the ventilator failure on the ventilator group, in that severe ARDS patients, there's a significant reduction of significant low number of ECMO failures in the ECMO group compared with ventilator failures. So that means there's a possibility, there's a suggestion that ECMO would be useful as a rescue. And not only that, it has shown that using ECMO would reduce the damaging ventilatory strategies like the tidal volumes, pressures, PEEP or oxygen levels to a minimum level. It is called ultra lung protection. For an example, if you need to maintain 6 ml per kg with a high PEEP level for a patient with ARDS, when you use VV ECMO, you will be able to maintain ultra lung protection, where you will be able to reduce the tidal volumes maybe to 3-4 milliliters per kg with low levels of PEEP and pressures. Complication-wise, in both groups, the complications were almost equal, except the bleeding risk and the thrombocytopenia, which is high in the ECMO group. Therefore, ECMO may be considered as safe as a rescue therapy. And the ECMO therapy is evolving, and the newer concepts are also getting evolved, where you may use spontaneous ventilation in patients with ECMO, or you may use awake, unintubated ECMOs, where you would use ECMO as a primary strategy rather than ventilation when it comes to respiratory support, where you will avoid all the negative effects of intubation and ventilation. And mobilization with ECMO would improve the outcome. But the thing is, these are evolving and data is minimum, and there are some reviews and pilot studies on this awake unintubated ECMO on patients with ARDS, COPD, and things are evolving. And finally, if you get the demographic data, following the 2009 influenza pandemic, there had been an exponential rise of usage of ECMO, whether it's VV ECMO or VA ECMO. Therefore, in time to come, you will be able to use ECMO in our country as well. And there are 2 stations where ECMO is available, but it will be more popular in time to come. And today, I discuss mainly the introduction and the technological aspect, physiological aspect, and therapeutics of ECMO. Following the earlier study, there had been 2 schools of thoughts where believers would think that ECMO would be useful as a rescue therapy, thinking of crossovers, and non-believers would think that it may be still not useful, think of a negative aspect. The choice is yours, whether to follow or not. Thank you very much. questions either from Dr. Chandana or from me. Sorry. Yes, so that's the problem, the cost and other factors, but hope it will be more freely available in time to come.